Hello, I'm Dr. Jason Westin from MD Anderson Cancer Center in Houston, Texas, in the United States. I'm the director of the Lymphoma Clinical Research Program and the section chief for diffuse large B-cell lymphoma. When I think about how to approach patients with newly diagnosed diffuse large B-cell lymphoma and select a proper therapy, there are multiple different considerations that come into account. The IPI, or International Prognostic Index, has been tried and true for a couple of decades and holds up in the rituximab era to still stratify patients based upon the crude factors of age, performance status, LDH, extranodal sites, and stage. That still works, and that's probably because those are accounting for disease biology surrogates, such as the aggressiveness of the disease and the ability of the patient to tolerate therapy. So that still stratifies patients in my mind to their prognosis, but in terms of actually selecting therapy, it doesn't offer us very much insight into patients who may not benefit from R-CHOP. Ultimately, that's still the consideration is R-CHOP is our standard, despite many, many attempts to try and displace that standard through the R-CHOP plus X approach. However, R-CHOP still remains king, unfortunately, nearly 40 years after the advent of CHOP and 20 years after the addition of rituximab. There are situations, however, where I would deviate from that in a standard of care setting, and that would include patients that have very high IPI and proliferative disease. So if a patient has an IPI of 3 to 5 and has a significant disease burden, a rapidly progressive disease, and is fit to tolerate more intensive therapy, I might consider using dose-adjusted R-epoch in that patient, although that's not standard. In the 50303 randomized trial comparing CHOP versus epoch, subset analyses did suggest a potential benefit for patients with dose-adjusted epoch who had high IPI. Not a standard that must be adhered to, but something to consider if you've got a patient that smells like they're not going to do well with R-CHOP based upon their presentation. And then the cell of origin is always something that we consider. The ABC or the GCB subtype, often based upon the Hans immunohistochemistry algorithm. But to date, that's not really held up in clinical trials as something that I would use off of a study to select patient therapy. That's something I still would adhere to the IPI and typically err on the side of giving R-CHOP if a clinical trial is not available. The double hit subtype, or the WHO classification called high-grade B-cell lymphoma with MYC and BCL2 or BCL6, much easier to call it double hit. That's a subtype that often has inferior outcomes with R-CHOP-based therapy if it's advanced stage. If it's localized disease, stage 1 or stage 2 without disease bulk, often patients will do very well and don't behave like the refractory double hit patients that we typically worry about. With those for advanced stage, I typically would not use an R-CHOP-based approach, not based upon randomized data, unfortunately, but significant retrospective data sets suggesting that intensive therapy such as dose-adjusted R-epoch, hyper-CVAD, Codox-M-IVAC, all of those different intensified therapies, if you can achieve a complete response, seem to do better than R-CHOP with a complete response. And in our center, we typically do not consolidate those patients with an autologous transplant. We've been waiting for something to displace R-CHOP for quite a long time, and we're all eagerly anticipating the final results of the POLARIX clinical trial. This is a large phase 3 clinical trial which randomized patients to receive R-CHOP versus so-called R-CHP-POLA or R-CHPP. And here the vincristine, or O, is exchanged for polatuzumab, the antibody drug conjugate against CD79B. And at the time of this recording, we have a press release that says it met its primary endpoint for progression-free survival. We don't yet know the magnitude of that improvement, so time will tell if that's something that potentially could be a new therapeutic option for patients with frontline large cell lymphoma. I think in the future, we need to do better in terms of defining these subtypes in terms of their response to therapies, not just based upon the biology of what's wrong or what genetic abnormalities there are, but doing so in a way that's therapeutically relevant and doing better preclinical to clinical, back to preclinical work, the bench to bedside axis, where we better define subtypes that are therapeutically relevant, not just elegant biology, but practical biology that allows us to select for therapies. That's the future, I believe, where we have better subtypes. And then lastly, I would comment also in the future, I believe that ctDNA is a coming technology that will be very useful for us in terms of better deciding early response or lack of response to therapy, and potentially allowing us to change treatments prior to a patient achieving a clinical failure. Patients having progression of disease potentially could benefit from an early intervention. That's not yet ready to replace PET CT scans, but I think in the next 5 to 10 years it will. So that's generally how I approach patients with newly diagnosed diffuse large B-cell lymphoma. R-CHOP is still king, unfortunately, nearly 40 years into its lifespan. However, clinical trials still are the best option for most of our patients, and the future is very bright.